Good afternoon. Welcome back, everybody. I'm Angelo Sinopoli. I'm one of the co-chairs of PTAC. We had great sessions this morning with a lot of experts and a lot of robust conversations, so I'm really looking forward to this afternoon's session as well. I'm pleased to welcome three experts who have experience in different types of ACOs for our second panel on specialty integration. You can find their full biographies posted on the ASPE PTAC website along with their overview slides. I'll briefly introduce our guests and give them a few minutes each to share an overview of their work and perspectives. First, we have Emily Brower, who is the Senior Vice President of Clinical Integration and Physician Services at Trinity Health. Welcome, Emily.
Thank you. Thanks so much for inviting me. So glad to join you all for this discussion and share a little bit of Trinity Health's experience, yes, as an ACO, but also as an integrated delivery network with a significant investment and broad geography in value-based care. So we could go ahead. I'll just give a little bit of that overview. I always start conversations about population health and value-based care with our Trinity Health mission, vision, and values slides. And that is because this work is right at the core of our mission to be a compassionate, transforming, healing presence within our community, to lift the health of the communities that we are called to serve. And so, yes, we, I think, are the leading health system and in value-based care. But that's simply because we are trying to transform the healthcare delivery system in order to improve the health of the communities we serve. So not sort of in an end of itself, but in a means to get to that end. And so I often get questions about, what drives the level and breadth of investment we've made in this work. And it's because of this. We just don't think we'll be able to really transform the health of the communities we serve under a fee-for-service payment model. So payment model transformation in service of care delivery, transformation in service of community health. Next slide. And so in this work, we are trying to move all payments from the lower left quadrant to the upper right quadrant. So from traditional fee-for-service all the way up to fully integrated total cost of care payment models. We are the second largest PACE provider. And to us, that's sort of like the original population health value-based payment model because it fully integrates all the payment and the services and really leverages the depth of relationships in the communities we serve that we have. So by integrating, including long-term services and supports and behavioral health, really the full breadth of services for the population. And so we just keep trying to move things from the lower left to the upper right, where we have the opportunity to deliver the most integrated care and to fully change the payment model. Next slide. And in terms of our portfolio today, 2 million attributed lives, as we like to say in value-based care, are people that we serve, and $11 billion in cost of care accountability. You'll see here the breakdown, which I think is helpful for today's discussion. A lot of Medicare, 50% of Trinity Health's business, fee-for-service business, is Medicare, so trying to transform the payment model, right? We're very much sort of each and every day trying to make sure all Medicare beneficiaries have that accountable home, either by being attributed to a Medicare ACO or if they so choose, Medicare Advantage. We have our own Medicare Advantage plan, and we take total cost of care accountability there as well. I mentioned PACE. Up until recently, we were one of the largest participants in the bundle payment program, and I included in my slides today just some of the value that we saw from participating in both, as a way to sort of start a conversation about integration and alignment. So a lot of good experience there. And then, of course, we have accountability for the health and well-being of our colleagues and their dependents. So we have first dollar accountability there for our colleague health plan. And then we participate in commercial and Medicaid plans, and one of our systems is in Maryland. So there we also got some experience with all-payer global budget. So lots of different programs. We sort of will raise our hand where we feel like we can get anywhere further up that diagonal and participate if the terms are reasonable. On the next slide, just teeing up some, this is some of our thoughts specific to, we often get a lot of questions because we have such an extensive participation in both population-based payment models and, until recently, episodic-based payment models. So why, what was our hypothesis around that? And that was really an ability to line and integrate at the moment where patients is really a critical period for people. They're in the hospital. That shift to next site of care is one that is fraught with possibilities for falling through the cracks or poor integration, poor alignment, and so wanting to specifically align at that moment and make sure that patients are getting that extra touch and services to get them to the most appropriate next site of care with the supports and services to take care of them during that critical period and then return them to primary care. So, so I've got a few points on here that I thought might be fun to touch on during the discussion. So with that intro, I will pause for our next subject matter expert.
Thank you, Emily. Next, we have Ms. Cheryl Lulias, who is the President and Chief Executive Officer at Medical Home Network. Cheryl.
Hello, thank you. And thank you for the opportunity to participate in this discussion with this esteemed panel. I'm really grateful. So we're a Medical Home Network, CEO and President. We call ourselves MHN. We're a not-for-profit, Chicago-based, and we have a vision to redesign care delivery in the safety net and, like Trinity and everybody else on this panel, improve the health of the communities we serve. So I'm going to talk to you a little bit about our model and our approach. So we've created a standardized whole-person model of care that we practice across our federated networks. And for us, that means a team-based care management at the primary care practice with the care team employed by the primary care practice, and that care team coordinates care across the continuum. So today I'm going to share an example from the Illinois ACO we created. It was a Medicaid ACO. The composition is 13 FQHCs in 3 hospital systems. This group is completely delegated for care management and has global risk for 175,000 Medicaid lives. And my hope today is that this example proves relevant to our ensuing discussion. So next slide, please. Great. So what is the problem we were trying to solve? We identified a subset of our membership who were high risk, high cost, and namely those who went to the ED or were frequently hospitalized for severe mental illness and substance abuse diagnosis. And so we analyzed our utilization and our cost data for the subpopulation. And the goal was really to understand potentially avoidable costs and what was contributing to them. So this slide shows that it's a little bit of a busy slide, but during the 6 months post-discharge from the ED or inpatient setting, how many people for our focus subgroup had at least one claim in each of these categories. So we had a cohort of 699 patients, And let me run through this. So the top yellow line, the first yellow line, what that's saying is 30 days post-discharge, only 50.5% of our population had an RX claim for psych or substance abuse. If you go to the next yellow line, that's saying that only 2/3 of our patients had follow-up with a behavioral health provider. If you go to the next line, that's saying only 40% of our patient population with these diagnoses saw their primary care physician within 30 days post-discharge. And then things that aren't highlighted, readmission rate was 19.2%. We've had it as high as almost 30%. And a third were back in the ED. So sort of the punchline was, over time, things were getting even worse. And so clearly we had a problem with our members not taking their meds and not being engaged in ambulatory care with behavioral health or primary care post-discharge. So let's go to the next slide. So this slide is the cost view. And this slide takes the population and breaks down different categories of severity based on CDPS RX defined categories and tracks the average monthly cost for the population that the subpopulation we were looking at. And the line in yellow shows, it's actually most expensive. It shows somebody admitted for alcohol abuse was $2,556, in cost the first 30 days post-discharge. So again, we had a significant segment of our population with the diagnosis we were looking at that were really expensive, that were in the ED and getting hospitalized, not taking meds, and not getting the appropriate ambulatory care. So this slide is what we used as the baseline measure for our target value-based program and construct, which I'll go through in a minute to support the model we did. So this was our baseline that we used for our VBP program. So let's go to the next slide. So what did we do with this information, and what did we do in terms of creating a nested model of care? So we looked at our data. We said, management model is, with care management at the primary care level, but you can see only a fraction of our members were going to their PCP post, ED or inpatient discharge. So we needed a new clinical model and a new payment model. So we found a community mental health partner to develop and implement, included community-based behavioral health trained care managers, as well as, access to the clinicians and workflows. So what we did is we engaged our community behavioral health partner to meet our patients face-to-face in the community. We used transitions of care and ED visits and inpatient transitions as the triggering event for the care teams to make contact while the patient was in the hospital, and then work to coordinate follow-up care. So they were our boots on the ground, so to speak, and they worked as an extension of our primary care-based care teams. So let's go to the next slide. So let me talk about recap the value-based construct to support the clinical model, and then talk a little bit about the outcomes so far. So the value-based opportunity for our behavioral health partner was that we paid upfront care management fee to cover the staffing model and tasks in care management, the weekly coordination, everything that we asked them to do to implement this model. And then we offered the back-end incentive for avoidable cost and utilization based on savings from the baseline I showed in the previous slides. And we split that 50-50. And so a little bit about outcomes and results, really super promising directional results. We don't have P values because our numbers to date have been small because we launched this construct a few months before COVID. And it's been difficult for us to enroll patients because our behavioral health care team has not had access to the ED or inpatient facilities because of the pandemic. So we have some good, promising initial results, but we haven't had savings to date, but we do anticipate that that will change in our current performance year. And I just wanted to share this, as an example of how the nesting thinking helped us innovate in both the clinical and the payment model. So hopefully this proves useful.
Yes, thank you. That's very interesting. All right, next we have Emily Maxson.
Hello, everyone. I'm Emily Maxson. I'm the Chief Medical Officer of Aledade. And I wanted to first start with a description of who we are so that will ground what we try to accomplish and our perspective on integrating specialty care. But before I do, wanted to say how grateful I am as well to be here and to present alongside Emily and Cheryl. So thank you for the opportunity. Aledade is the company that brings together independent primary care doctors across the country, and we form and manage risk-bearing contracts and accountable care organizations. So as of this year, we are the largest independent primary care network in the country. We have about 2 million lives under management, 5,000 PCPs, 1,500 practices. And we got our start with the Medicare Shared Savings Program, expanded to Medicare Advantage, commercially insured patient populations, and Medicaid. And basically our rule of thumb is that we want to be able to impact health and wellness across the country. We want to be able to curb excess healthcare utilization and runaway spend in this country. And we want to be able to eventually be the best in care for our elderly and disabled populations. And independent primary practices are an inspiration to me and to us every day. And that's really who we serve. And we help them provide the best care they can to their patient populations. So if you can go to the next slide, we do this through a combination of technology-driven services and an app platform. And we've been exploring ways in which to integrate specialty care and help manage specialty care over the past 8 years, and have a number of lessons here that I'll touch on briefly. Again, we operate in independent primary care, and so we are serving up insights. We're helping them to reinvest and double down on primary care to avoid costlier sites of service and escalations in patient health and poorer outcomes for their patients. So by investing more in primary care up front, we can stave off the complications and avoid unnecessary emergency remedialization and hospitalizations. So when we think about most of our interventions, they are usually things like teeing up the patient populations in need of annual wellness visits. They are things like helping them understand which patients have been released from the emergency room or the hospital or the skilled nursing facility so that they can have the data to embrace their patients in a timely fashion and engage them in care. And as Cheryl had mentioned, it's so important after that acute event to really embrace the patients back into their medical home. So when we think about specialty, a lot of the time we have to pause and say, okay, well, what is our effect lever? How can we help our practices patients once they are outside of our practices walls? How can we help our practices understand the data around specialists in their community? And how can we start to impact practice patterns? So I'll give you a couple of different lessons that we've learned over the past 8 years trying to impact work outside of the primary care arena. One is that we have very entrenched referral patterns in our primary care networks. These relationships are often built off of years of experience. They're built off of community relationships. We have lots of people who refer to their children's friends, parents, or the people they went to medical school with, or the people they see at church. And they have a beautiful relationship as long as the patients are getting excellent, timely care, and the primary care offices are getting excellent, timely feedback about that visit. And what we know is that that's not always the case, unfortunately. But even bringing data on specialty patterns and quality, it's still hard to get them to change that entrenched pattern. we have had experience with 3 different e-consult vendors. So for those of you who are unfamiliar, an e-consult is when you can use your smartphone or your computer to send a question to a specialist electronically. There are some that are synchronous, where you get a response back within 30 minutes to an hour. There are some that they send them out and then you might get it back the next day. And we've had a number of experiences, and in all 3 of those instances, which span synchronous and asynchronous, what we found is that clinicians loved the e-consult platforms, and they almost never used them. And they would cite such learnings as, well, it's difficult to remember that this is available to me. There were also learnings, and we made sure to do it in a contract or payer agnostic way so that the service would be available for anyone in their patient panel and not just for a subset of Medicare, for example. And still, it wasn't ingrained in their workflow. It was hard to remember that this was something they could access. And then I think the other really interesting finding there was that we had robust utilization in our nurse practitioners and physician assistants. And we also had robust utilization for patients who didn't have adequate insurance. Our underinsured or uninsured patients, they were almost using it as an alternative to sending the patient somewhere where they wouldn't be able to afford, and they would get the question answered and try to manage them in primary care. But even that robust utilization relatively wasn't enough for us to sustain any of those pilots. Utilization was just too low. I also wanted to mention that we have had great success with highly targeted third-party intervention. So what do I mean by that? We aggregate data from a number of sources, from the practice's electronic health records, from Medicare claims and other insurer claims, from pre-adjudicated claims data in the practice, from hospital HIEs, health information exchanges, and other sources. And we can use all of that data to try and understand, through machine learning and artificial intelligence algorithms, which population of patients might be most likely to benefit from a given intervention. The first one we tried was for complete advanced care planning. The data suggests that 98% of elderly patients have never had a conversation with their primary care doctor about their end-of-life wishes or their wishes in the event of complex illness. We also know that there's a lot of care that's provided at the end of life that isn't necessarily in concert with what the patient would have wanted. So what we tried to do was we tried to say, look, our primary care doctors are extremely overworked, and we know that they can have beautiful conversations about preferences in complex illness, and we also know that they may not have time to chase down the documents and tie the knots and communicate with the sister in California and the daughter in San Diego, both in California, and the son in New York. There we go, different parts of the country, and that it takes an average of 2 hours to do this right and comprehensively. And our providers, the way that Medicare reimburses it is for a 16-minute conversation. So you can get the ball started, rolling down the hill, but there's a lot that needs to be done administratively in order to ensure that a patient's wishes are not only understood, but documented and shared with family members. So we contracted with a company called Iris, and we did a 3-year randomized control trial where we took patients at high risk of mortality in the next 12 months, and we assigned them to either have this Iris introduction and have a complete advanced care planning conversation done, or usual care with their PCP. And what we found was that the patients were extremely appreciative. Our Net Promoter Score was extraordinarily high for the intervention. The practices also gave it a high NPS. The patients, their families, the doctors were happy. And at the end of the day, it was cost effective so that we could fund it at no cost to the patients or practices. So we ended up acquiring that company, and that just goes to show, you can use a third-party intervention, and as long as they are in collaboration with the primary care practices and don't cut them out, it can be really a successful partnership. We're now doing this with kidney care management for patients whom we've identified to be at high risk for transitioning into dialysis in an unplanned fashion, and the preliminary results are pretty exciting. So we're excited to do more of this. What kind of intervention can we find, whether it's for COPD, for congestive heart failure, for behavioral health, and really help augment the services in the primary care provider's office. So that's probably where we've had our most success. We also have tried inviting specialists into primary care ACOs, and what we found is that those clinicians often bring attribution of patients in, but without primary care end-to-end accountability. So we tried this with cardiology and we tried this with nephrology. And so the patients that tend to see those doctors a lot can be very sick patients and may not have a strong relationship with their primary care provider. And so it just doubled down for us that primary care is still very key and needs to be forefront. And in the future, should we invite specialists to join our primary care ACOs, we would want to guarantee that their patients that they're treating had robust primary care relationships. And then finally, when we try to partner with an external entity in shared risk, it's very interesting because you have to help understand that there's overlap between initiatives. So we tried early on in Aledade's tenure to think about how we might delegate cost to a kidney provider, for example. But that doesn't mean primary care stops. The primary care clinicians are still embracing patients after escalation in care, and maybe so are the kidney providers. So when you think about affecting in a delegated way, you have to have those upfront conversations about cost accountability in order to move forward efficiently. So those are some of the lessons we've learned. I hope they're helpful as we continue the rest of the discussion.
Thank you, Emily. Yes, that was very, very helpful and very informative. And I'd like to thank all three of the speakers for sharing their insights and overviews. We have some prepared questions that we're going to ask this group, and committee members will also be able to ask questions as time is permitted. As you know, we're focusing on specialty integration at this meeting, and wanted to hone in on ACO perspective during this session and different types of ACOs. So I'm going to start out with the first question. And that is, what approaches are most commonly being used to facilitate coordination between primary care and specialty care providers and different types of ACOs? And I'm going to start out with Emily Brower.
Sure. Thanks, Angelo. So our ACOs are multi-specialty ACOs. So back to sort of the reason we're doing this work, we want as much of the community, of the provider community in the ACO. Most of our participants are independent in the neighborhoods we serve, whether they're primary care or specialty care. Some subset of those are employed by us, but we're very inclusive in terms of who's in our ACOs. So there are physician-led, physician-governed, includes both primary and specialty providers in those leadership and governance positions, in the committees, in the care pathways work, the care redesign work. So so I would say for us it starts with including the specialists in the ACO. It certainly introduces some of the complexities Emily from Aledade mentioned, right? Because we get attribution, but we want that. We want to get as many people in the community we serve and as many of the providers in the work. So it does introduce a lot of complexity, and so how we get at some of that is, one vehicle is the care redesign and the care pathways work, where we involve the specialists and primary care providers in that together. And then the other piece is just the day-to-day care coordination. So making sure that for high-risk patients that get our care management, sort of RN, social worker care management, or PharmD care managers, that they are in the practices meeting with both the primary and specialty care, particularly those in ACO parlance, attribution eligible specialists, so cardiology, nephrology, oncology, pulmonology, that they are offering that same care coordination approach. And with some of those subspecialists, some of them have their own sort of care coordinator, care manager. So most typically in nephrology and oncology, they have members of the care team. So we're really flexible about including those folks as authentic members of the care team to have that full integrated patient-centered care plan. So it requires a lot more coordination and integration just in our, what I would say is usual work we do in an ACO that may not look much different than what other ACOs might do, except we pull the specialists into that work because they are in the network. They have attribution, they are in leadership and governance, and so we just do that work together.
Perfect, thank you. Now let's go on to the other Emily.
So I highlighted some of the challenges. I think we do have a number of multi-specialty clinics, and one way that we found we can be helpful is by helping them understand the patterns of their patients. And when we think about the insights that are usually available to our practices, they don't include information from outside of their own clinic's walls. And so when you get that file of information from CMS and you can see where they've been regardless, it's an eye-opening moment for the clinic to experience. So one thing that we've done a lot of, which the multi-specialty clinics are very hungry for, is analyses of when the patients stay in that clinic and when they go elsewhere for specialty care. And if they do, why? How can we follow up and understand what is lacking or what could be made better about the patient experience? And so what you see is great quality improvement on the part of the multi-specialty clinics and a better patient experience to boot. So it's very well aligned. We also think about how we can make sure that our patients' chronic diseases are well understood, documented, and attended to on a yearly basis. Specialists often have better insight into some complex conditions in their categorization than the PCPs do, especially if they're the ones managing it. So we try to help our specialists understand what it means to be as specific as possible in their documentation and communicate back to the primary care practices so that they too understand the level of complexity a chronic disease has reached and what they need to attend to as they're attending to the whole person and not just one subset. So those are a few examples of the ways in which we can work with specialists that I didn't mention in my introduction. Let's see. I think I'll leave it there for now.
Okay, thank you for that. Let's go to Cheryl. Would you like to make some comments?
Sure. I think the one thing I'll drill down on is this is a place where we've had some success using eConsult. Emily talked about that, but like she said, you know, it's because it was really ingrained in the workflow. And so we used eConsult to support our collaborative care model for depression. And we use eConsult to engage psychiatrists to support primary care practice caring for the patients, both in care and medication management. And that's been really effective in putting patients in remission and reducing depression. What we've actually seen is our results mirror everything we've been able to find in the literature. That was a great example of using eConsult to facilitate specialists. But again, it's because we have very clearly defined workflows. I think eConsult has a lot of promise, but it's challenging on a more global basis. The other thing I'll say is when we have used eConsult, it's really important that primary care take the time to provide detailed explanations what they want addressed from the specialist. And that's another key imperative to make that type of technology useful for coordination between primary care and specialty.
Thank you. So obviously there are different types of ACO models out there, from an integrated delivery system to freestanding ACOs to purely primary care ACOs. A lot of those are represented right here by this group. So we're interested in understanding across those variety of ACOs, what kind of challenges are you seeing that may be different in terms of improving specialty integrations, and what kind of challenges are you seeing that may be different among the type of ACO you are? And maybe I'll go back to Cheryl again on this one.
Okay. So I'm going to give a specific example with regard to REACH. So we're a REACH, and and it's a new program. So we're early days, but, we have been contemplating this because, we don't have the ability to use any kind of narrow network or prevent use of low-value providers. And so we're looking to see how we best improve specialty integration in the construct of the REACH without any levers. So it's not really... that's a challenge we're focused on addressing. I don't have any answers, but I think that's something I wanted to raise in these types of CMS value-based models. It's a challenge that needs to be addressed.
Yeah, thank you. How about Emily Brower?
Sure. I'm not sure that it's, specific to the kind, the shape of our ACO or the kind of ACO we have. But I would say, for the most part, the specialists in our network like being part of the network. They like the coordination. They like getting the right referrals, right, where they feel like they're sort of highest and best use of their time. We do have, we need to flex on the way we work if they have care coordination, navigators, types of services in their practice. Looks a little different, but we can do that. I would say we're going a bit deeper on kidney care. Sounds like Emily Maxson is doing that as well. And there, we've gotten way more into what is it going to take to allow the nephrology practice to see more patients. So if we're referring to them sooner in the disease process, and they're already really full, right? How do we partner them, bring in a nurse practitioner, another member of not just sort of care management, but on the medical management side to support that capacity. So we're doing some work there with a partner in Chicago that I think is super promising. And then the other piece is, how do they make time in that busy schedule? And if they're not sort of documenting and submitting RVUs for that, is there some PM support? So we're working that out as well. So that's where we're looking for greater integration beyond what I would say is sort of typical care navigation, care coordination, to do more integrated medical management. And that is requiring some different thinking. I don't know that that's specific to us, and we think it's great. It's like really where we need to be. So I would say less maybe challenge, more as like a really good opportunity we think we're going to learn a lot from.
Perfect. Thank you for that. Emily Maxson, would you like to add some comments?
Sure. A couple of things. I think that we're in a similar position to Cheryl with, we don't command and control any of our practices, right? And especially not the specialists who are not part of the network. But one thing that we can influence is the provision of data to our primary care practices. So for example, in gastroenterology, we have practices as everyone does, who are referring their patients appropriately for colon cancer screening. And what we find is that if you take a look in the data, unbeknownst to our practices, there were a number of GI doctors in certain communities who were routinely providing upper and lower endoscopies for every patient referred for a colonoscopy. And so imagine the power of giving that data to the primary care doctor who sends all their referrals there. And we actually had primary care doctors visit the office of one specialist, for example, and say, look, when I send you my patient, I trust you. I trust that you're going to do what I asked for and not a non-evidence-based procedure that could put my patient at greater risk. And that GI specialist stopped providing those additional procedures unless it truly was clinically indicated. And so I think that there's a lot of power in the referral relationship in the community, and with data transparency and providing these very patient-centric, quality-based assessments, we can empower really interesting conversations so that the pattern of care matches the expectation. So that's one example. The other example, I think, is that just like in primary care, our specialty practices are challenged by insufficient resources to address social determinants of health and other factors that are outside of managing medically a chronic disease with medicine and therapy and treatments and procedures, right? There's so much more that goes into taking care of a patient. So where we can bolster up those third-party solutions I mentioned, or even just help our practices learn how to do better chronic care management, we can also help the specialists to enrich the quality of their visit, to make sure that what they are recommending has a better chance of being implemented in the context of the patient and everything else they're dealing with. And so I think upskilling care management or providing extra resources for practices who can't do a care management program at home can be really effective in improving both the specialist and the primary care experience, and is a no-brainer for the patient experience.
Thank you. So we had a lot of good, robust discussion this morning, so I'm going to ask one more structured question, but then I'm going to open it up to the committee members to start asking some questions too, and we certainly have other structured questions we can ask too as our time moves forward. But one of the things that we're interested in is nesting models, and that's become more and more in conversation. How do we think about those? How do we structure payment around those, et cetera? And so the question is, what do you all think about nesting models, and what support the ACOs need to participate in total cost of care models that might have nested programs within the ACO? Let's go back to Emily Maxson for that. I'm sorry.
Sure. I think that the most important thing is that if you nest something, you're inherently providing different services to the same patient population, and you have to tease apart, right, who's accountable for what, and when benefits are achieved in a complex model, what is that thanks to, right? And how do you sort of distribute the return that provides financially? Because it's expensive to provide value-based care, and practices will not be able to sustain if they don't get to continue to share in some of the savings that they have worked so hard to achieve. And so I think that if there can be clarity on which programs are accountable for which piece of the pie, that would be helpful.
Great, thank you. Emily Brower?
Yeah, thanks. So I suppose nesting is sort of it's in the eye of the beholder, or whatever the right term is. When I talk about nesting, I see that as, rather than have these different models, CMS models in this case, if we could just use CMMI as an example, right, where they had next gen and bundles, and those were exclusive, meaning if patients were attributed to the next gen ACO, and I think this is true for REACH as well, they're not included in the bundle payment program. And then on the Center for Medicare side in the MSSP ACO, you have what people commonly call overlap, right? You have model overlap. And if you're all one, which is true at Trinity Health, all of our ACOs are now in the MSSP model, and we like bundles. So we like when those come together. And so when we think about our experience in sort of exclusive models and our experience in overlapping models, our concept of nesting is the ACO, or the population-based model, has total cost of care accountability. Let that entity then decide within that total cost of care what episodes or what specialty care they want to deliver as the entity that's accountable for the outcomes of cost and quality for the population. They will make rational decisions. And so give the ACO the ability to nest those models, make those decisions. An example of that would be to say, I, as an ACO, will convey to CMS, I want to participate in the bundle payment program for my population for these episodes with this payer, with this episode initiator or provider at this price. In other words, it's really taking the bundle payment construct and bringing it inside the accountability of the really big bundle of the whole population and all the services they need. So that's the way we think of it, is a way to get out of exclusion on one end and overlap on the other, and let the ACO make those rational decisions. As an integrated delivery network that has a lot of hospitals, we would also like to be that partner for other ACOs that don't have specialists and hospitals in their network, right, where they could make that rational decision, and we would offer these episodes, these bundles, these providers, this price. So really to kind of create that marketplace, if you will, for an ACO, again, that has the full accountability to be able to, looking at its data, and selecting where they see there's opportunity to improve care and reduce costs, and then making those rational decisions.
Great, thank you for that. Cheryl, you want to make some comments?
This is a hybrid of the current question, a little bit of the before, but one of the challenges is that attribution, piggybacking off both Emily's, is usually to the PCP, even if the plurality of care is done by the specialist. So, we continue to think, so the specialist is an incentive to manage total cost of care. And so we have been thinking about how to build in care management and reward for care management and coordination. We've also been thinking about, for select services, the opportunity to attribute specialists when the plurality of ambulatory services provided are by the specialist, and then again provide a care management fee and access to shared savings. This is sort of a blueprint we're toying with for more global thinking of how to integrate specialists in the event that, in cases like ESRD, oncology, really the preponderance of care is really done with the specialist. So that would be, the additional thinking I would build to this. You have to have enough patients to make it feasible. It works best with an integrated group practice. That's some of what we're thinking at present.
Perfect. Thank you. These have been great comments, and we certainly, as I said, have other structured questions, but I can't imagine that my colleagues aren't eager to ask you some questions of their own, so I'm going to open it up to the committee members and ask them to pose some questions for you. I can't, yes, go ahead, Jay.
Yeah, I have two. One, in terms of using the third party for e-consults, and even though the providers really liked them because they weren't integrated into the workflow, you got low utilization. Were you also using their network of specialists, or were you using their platform for your network of specialists? And do you think that may have had an impact on utilization?
So I can take that one first. So we've tried it both ways. We tried first a platform that leveraged their own network of specialists, and they prioritized people from highfalutin places, and it was anonymous. And our independent doctors across the country did not like that. They didn't like the anonymity of that platform, and they would have preferred at least to know who they were getting their advice from. So I think that that informed our next adventure, which was going to be to try to help develop the local network and help enroll the local network as preferred relationships. And in that model, we used two things. The local network would have first go at the synchronous e-consult. But if they didn't answer expediently enough, that question would go out to the broader network. And the providers actually liked both models, but the ability to have access to the local model didn't meaningfully change the integration into the workflow piece. I think if we were to have started with EHR integration and other flags within the point of care tools to advance the workflow, we might have had more success. But we work with over 100 different EHRs across our network, and it wasn't feasible for us in our organization.
Okay. I don't know if any other members want to take a crack at that. And part two would be for everybody, to what extent are you using virtual specialty care to help to drive integration? Do you use that? Do you leave that up to the specialists themselves, or do you kind of build incentives in to utilize virtual care to help drive integration?
So this is Emily. Other than making a platform available, so this, like many at the start of the pandemic, we quickly stood up a virtual visit platform and made it available to our entire network, so including the specialists in our network. Other than that, sort of making it quickly, very quickly and easily accessible without a cost to the network. We haven't done anything systematic in terms of workflows or utilization or anything like that.
Anybody else have any comments for that question? If not, I'm going to move to Larry. Go ahead.
To the former question on e-consult, we just used one network, the specialty network of one hospital system, and again, had pretty prescriptive workflows, but also provided access to 43 specialists and had SLAs like Emily referenced, where we had really rigid SLAs to make sure that people had predictability when they went to an e-consult on response. And it was really successful with a collaborative care model. But in general, we also saw a lot of success with derm, GI, and ortho for quick questions. So for what that's worth, but we had one group focused. We didn't have multiple networks, and adoption has been okay for the generally consult questions, but much better where we had focused ingrained workflows and focused models.
Okay, thank you.
Thank you. Larry, you had a question?
We can't hear you, Larry.
I remember the two buttons. Got to put the hand down and unmute. I've really enjoyed the discussion here, and it's similar to one that we had probably at our June meeting last year, where I'm hearing a top-down approach from a couple of you, where from a system level you are taking full risk and then trying to implement the providers. And then on the other end, we're hearing a bottom-up approach from a large primary care network that's going at the problem from a different view. This is really interesting, and it spins the gears in my head. To me, there's a common theme, though, and I have not heard from any of the three of you enough blocking and tackling on this to make me satisfied. I heard the statement from somebody that said that 60%, it works best when 60% of the primary care's income is coming from capitation. Well, what about your specialists? How do you get the hearts and minds of those specialists? It's very fine to have an individual doctor go and talk to another specialist. I mean, that's fine. But where are they taking risk? How much risk are they at? How much of their income is at risk? How do you get their hearts and minds to participate in value-based care? Unless you have mechanisms in place, we're going to be having this discussion in 5 years again.
So this is Emily. I don't know that I'm going to give you a satisfactory answer, because frankly, when we talk to our specialists who are very involved in the leadership and governance of our ACOs, they said, just remove barriers for me, get rid of the pain points. Don't send me a check. Don't give me that's not what I need. What I need is better coordination of care. I need to get the right referrals. I need to build relationships. That's where the network, the clinically integrated network, that's sort of our operating structure, provides the most value to me. I mean, we are, as I mentioned, with our one of our nephrology groups, getting a little bit deeper. But that's just not what I'm hearing from our specialists, right? We went down the road of, let's choose some mix measures and build an incentive around that. No. Then we said, well, let's do a PM based on attribution. No, those were not meaningful. At the end of the day, what our specialists told us is, we want to actually be part of a medical community. We want relationships. We want the right referrals. We want support for our most complex patients. And we want, if we get people attributed to us who really need primary care, please find us help on primary care. We don't want to be doing all this, the management of primary care focused disease and prevention. So that's what we do. So I understand why you're asking. I get that. I'm just saying we got a lot of specialists all across the country, and that's not what they're asking us for.
They're afraid you're going to demand it.
I think we need to demand it. And I love that question, Larry. And I think that the problem that we have is that specialists truly thrive in a fee-for-service system in a way that primary care doctors and clinicians don't. And so when we're trying to really meaningfully shift from a fee-for-service paradigm to one of value, they don't stand to win. And I think one really interesting example of this is in retinal injections for macular degeneration, right? There's more than one medicine out there. They're biosimilar. It's the same thing, drawn from a different bottle. One costs $2,500, one costs $60. And yet, we do not see universality at the $60 drug. It may be because of the 2% administration fee. It may not. There may be true and legitimate beliefs that one drug is better than the other, and I want to honor that because I'm not a retinologist, and that's not my bailiwick. But I think that until we have a payment system that demands specialists pay attention to value, we're going to be the tail that wags the dog.
That's someone speaking from the bottom up.
Thank you. Cheryl, any comments to add to those?
Well, going to the fee-for-service, doesn't count on care management or assumed coordination. Specialists don't get paid to do that, similar to what Emily said. And where it makes sense to attribute patients, to the specialist, and then you could wrap VBC around them, which is, just select cases. That's one potential solution. Also, Larry, you talk about ground up. We do have in our total cost of care savings a pool for hospital and specialists, but it's not the full answer. It's just beginning to reward specialist care and have them focus on total cost of care. But like Emily said, the fee-for-service system now isn't set up to accelerate the change we need to see.
Thank you.
Thank you. Jennifer, I think you were next with a question.
Thank you so much for great presentations and your insights. I actually have two questions. My first question is, we heard you describe how important flexibility is as leaders of accountable care organizations in developing incentives and relationships. But I'm curious, are there any, in your experience or in your opinion, are there any specialists or conditions that you think should not be included within a VBP model that's tethered to an ACO? And then my second question is around multi-payer alignment. How important is that, or has that been to the programs that you've described today?
So on the first question, this is Emily Maxson, and I would say that all conditions should be gained because all conditions are important to the patient, and we have opportunity to make improvement no matter what. If we think about something like oncology, it's most often a rude surprise for the patient. It entails exorbitant costs, and to tell you the truth, I don't think that we should be trying to convince a patient out of the state-of-the-art drugs, no matter what the cost. But where can we help? We can help on better coordination of symptoms, on palliative care, on complete advanced care planning. There are so many patients who aren't given the appropriate antiemetic to stave off nausea or vomiting after they start on a very toxic therapy. And so it's no surprise that they're in the emergency room with nausea and vomiting. So what would happen if we embrace those patients in an oncology model, not to decrease the drug total cost of care, which is, I think, unpalatable to many patients and families, but to embrace patients in the way that we can and alleviate suffering as much as possible and enable them to be at the helm of their care planning.
Great. Emily Brower?
Yeah, sure. I would say include them all, right? So again, back to why we do this work at Trinity Health, we want the whole community in. So we are a carve-in kind of place. And so with that, as I said, always comes lots of complexities, but we want, just for the reasons Emily Maxson so eloquently pointed out, we want it all in. On multi-payer, I would say it's very important, right? We are providers. And so, as everyone knows, providers don't really practice differently. Yes, we can bring them extra tools and supports and insights for some populations, but at the end of the day, they have a practice of patients. They're going through their day. The more patients we can get into these models, the more that transformation actually helps them in their daily work. Right? And so that's what we want. Our goal is to get all patients who see Trinity Health as their medical home into a value-based payment model. And we work hard every day to do that. So yes, multi-payer alignment, yes, absolutely. But we also, we work as hard as we can with what we have when we can get it. And that's why I said we tend to raise our hands and get in as much as we can. It's just to keep the momentum, carve it all in, all the payers, all the providers, because that's sort of in service of improving the health of the community, everybody in the community.
Right. Cheryl, you want to add to that?
One model, multiplayer, that's why we like RICs, because full flexibility of the care team. And then on the former, we really believe one practitioner needs to be responsible for the full continuum of care. So like both Emily's said, it's all in. And then we work with our team-based care approach to coordinate and collaborate with specialists. And again, the only thematic thing I would add is in some cases that leader could potentially be the attributed specialist.
Okay. I think next on the list was Chinny.
Sorry, trying to unmute. Hi, everyone. Thanks for doing this. This is and the work you do every day. Cheryl, great to see you again. I know we've interacted a few times over the years. So this question is for Emily, Maxson, Cheryl, and then Emily in that order. One of the things that I haven't heard sort of in this conversation, and as if this isn't complex enough, I'd like to add another layer on, is the concepts of health equity as they're integrated within the specialty world, right? And so, as you think about health equity in primary care, or inequity in primary care, it gets exacerbated when you start, anybody who's tried to get a Medicaid patient in to see a specialist understands, the difficulty there. So when you guys were looking at how you delivered care to different populations and particularly populations of that sort of cohort, how did you think through it in your ACO? How did you implement it? And how did you get your specialists to play ball?
So I will answer with the caveat that we have specialists in very few of our practices. Health equity, I think, is core to the work of value-based care because we are not embracing value-based care if we leave patients behind. So one thing that we are trying to do is first model this by integrating disparity measurement across all of our organization's key performance indicators and metrics, and really starting the work where we have the most glaring disparity, which was for us our blood pressure control rates in severely poorly controlled blood pressure for our Black patients. So we did a lot of work on that. From our partners, whether it is a specialty-oriented partner or not, we talk about health equity and ask what they are doing from the very first conversation. We ask them to show us data about engagement rates across socioeconomic levels, across rural versus urban distinction, and across race and ethnicity. And we really try to make sure that when we're using machine learning algorithms, we do not allow the bias to creep in that is a hallmark of machine learning. So if machine learning is acting on existing data sets, which require healthcare utilization, then our patients who don't access the healthcare system won't have the inputs for machine learning. And so they will be regularly deprioritized from machine learning-based algorithms. So we retrain the algorithms and we do deliberate things so that we make sure when we are targeting patients for kidney care management, for example, that we do not inadvertently worsen those disparities because we're intentional about it. So I think the intentionality is really my main point with where we're starting to be intentional ourselves and to ask for intentionality from all partners and specialists with whom we work.
Yeah, really well said. The core of our whole care management process we start our whole process by screening on addressable social determinants of health. So we are working to capture medical, behavioral, and social from the get-go, and we form our care management process based on mitigating the addressable social determinants of health as well as medical. And so we actually risk stratify based on social determinants of health. And we've proved that approach is predictive of prospective cost and utilization, but it is front and center in our holistic approach to, team-based care and care coordination. So our care teams who work with primary care are always focused on social drivers of risk and mitigating those with the goal of improving health and focusing on disparities. We communicate that and what we're doing, in coordination with specialty care, but we also have some tools like a baseball card that we share that shows the common care plan goals or things we're working to address, as well as longitudinal snapshot of care, including meds and utilization. And we share that via the EMR. And so that's something that's available to both primary care and specialists who are managing the patients. But the care team that is end-to-end managing continuity of care is very focused on social drivers and then communicating and integrating with all the clinical practitioners serving the patient to ensure that everybody knows what's going on with the patient. Especially post-discharge, we participate in a flexible housing pool, and all members of the care team know when we're supporting a patient and moving them into the flexible housing pool to assure we have a stable post-discharge plan and supportive services post-discharge. So, Chinny, I don't know if that answers the question, but it's central to the whole care model, starting the process, focusing on social drivers of health and risk stratification, including AI, all incorporates this. We have a common care plan. This is always front and center for all people to understand what's the medical risk, the behavioral risk, and the social risk, and what are we doing to mitigate each of these factors.
Emily Brower, anything to add?
I would say this is where we, in our sort of ACO world and Trinity Health, really benefit from the commitment of the delivery network to eliminating disparities, bias, and racism. We sort of have that power part of that, and so it is sort of just how we do our work, for which I'm very grateful. Specific to and how it shows up in some of our work in the ACO, I'll just use one example because it's one I think is really nice. Connection point is I can assume, I think, that every ACO out there is trying to reduce preventable hospitalizations, sort of using that very common, it's good to have a common measure of ambulatory care sensitive condition admissions, the ARC, AHRQ measure. So it's a measure in the ACO measure set. It's a measure that many people embrace and work on. When we were digging into that, where we saw, not surprising really to anybody, I'm sure, is where we had the greatest number of preventable admissions, so admissions for things that we should be doing a good job in the ambulatory space, is in for those who are dually enrolled. And within that population, for patients who are Black and dually enrolled, the greatest number of preventable hospitalizations, so work we should be doing a better job with, a standard measure. So we're able to take that measure and put it into our Trinity Health System scorecard, of which we have a very few number of the most important measures. How are we doing as an integrated delivery network, improving the care for the communities we serve? So all of our leaders across the great nation of Trinity Health are working on that, are working to reduce preventable hospitalization. So it's a utilization measure. It's common to our ACOs. We get that data from CMS. It has a flag for the duals, right? So we sort of started with, well, what's an easy way to measure? Are we making an impact? And we are seeing some good work coming out of that focus, really just amplifying that disparity and putting together explicit care models. So we have a community health worker workforce that we then said, okay, we're going to dedicate the time and energy and focus of those folks to those people who are dually enrolled in Medicare and Medicaid within our ACOs, because we can find it, we can measure it, we have a baseline, there's benchmarks out there. So that's just one example of how an ACO, and it's just like everyday work, I would say, can take that and focus on reducing something like disparities in care.
Perfect, thank you. So I think we have questions up next from Jim Walton and then Walter Lynn after that. Jim?
Hey, thank you. I appreciate y'all spending some time with us and sharing your thoughts. As the conversation's gone on, one of the things that kind of popped in my mind has something to do with some market dynamics that come out of Dallas, Texas, that I'll just kind of briefly comment on, which is, and it kind of is supported by the literature that shows that health system owned and operated ACOs maybe don't save as much money or don't perform as well financially as independent. And there's been some thoughts that maybe consolidation pressures and just has created some anti-competitive behaviors in large markets. And so one of the questions that comes up for me when we think about advising CMMI and CMS around integrating specialists is what would y'all think? What do y'all think as SMEs around what could CMS, CMMI do to maintain a competitive marketplace while simultaneously creating incentives that move specialists along the continuum of taking accountability, being accountable with our primary care physicians, recognizing though that the marketplace is continuing to consolidate, and that consolidation pressure has almost a reverse anti-competitive behavior, and which drives prices up or holds prices up. And so I thought I'd just ask that question about the design that you might recommend. I heard Emily say something around, Emily from Trinity, saying something about, well, just let us do it. Just let Trinity decide how to do that. But with enough market power, you could say, I'm going to do it this way, and it could actually be an anti-competitive decision. Not that you have a governance decision like that. So how do we create a sustainable system that's patient-centered, that has the proper incentives, but CMS and CMMI understand what you want to make sure that the system that they design for your ACOs is pro-competition?
So this is Emily. I'll jump in. What I was trying to maybe perhaps ineloquently describe before, I think of as very pro-competitive, because what we're saying is give us we have lots of data in our ACO for those. So for those patients who are attributed to our ACOs, we have good data on the specialists in our network and some data on specialists outside of our network. But what we would really love, and sort of we put this in as CMMI was going out and asking for input from ACOs around what data they need. We want to know, we as an ACO, and I think I can speak for others, we want to know who the high value, right, high quality, low cost specialists, people who are good stewards of the dollar, of the healthcare dollar, who those are, so we can bring them into our network and work more closely with them. And then for those in our network, we want to be able to do have that same insight, so that really it's not so much about consolidation as it is on having the care go to the highest value, highest quality, best steward of the dollar provider. And most of our providers are not employed by us. We are not necessarily looking to have to own that. So when I was thinking more of ACOs than Trinity Health specifically. But I do feel like it creates a marketplace. So which is transparency. I mean, in the utilization or cost data, you're only getting a little piece of the picture, right? And so we're working with folks who have these broader data sets to say, how do we get a quality? Let's look at sequelae. What are the downstream measures of an effective episode of care that goes past those days, so that we can really have better insight into how care is being delivered, so we can make rational decisions based on our commitment to quality, outcomes, cost, affordability, equitable care.
Thank you, Emily. I want to remind the group that we only have 10 minutes left, so I don't know if we'll get to Walter's question or not, but if any other participants want to make any comments about that before we move on to Walter's question?
I can chime in briefly. In one of our practices in Delaware, they have 90% of their patient population on value-based care contracts. And so 40% of their revenue comes from value-based care and 60% comes from fee-for-service. The reason that I mention this here is that my first thought was, well, could we go towards some sort of payment model through CMS where we gradually promise to convert a piece of specialist revenue towards value-based care and total cost of care versus all fee-for-service. And then I thought, well, the backlash against that would be that many specialists would just stop serving our elderly patients, and that would be catastrophic. So then I was trying to think about just price transparency and value transparency and quality transparency. It's really hard to compare and contrast relative value among specialists today. We're paying through the nose to do it right now through an external party that does nothing but this. After we tried to do it in-house, and it's just there's so much complexity. It's really hard, for example, to tell the cost of a procedure in one location or another by provider, because some providers practice in facility fee area locations in part of their week, and some of them practice in an independent freestanding in part of their week. And so my point is that price transparency is really hard and value transparency is harder, because it would also be incorrect to provide a unilateral claims-based view on specialists, because we know that bedside manner isn't captured there. We know that communication with primary care isn't captured there. So I think that probably the most practical way to start that wouldn't risk our Medicare patients being out of specialty access might be to start with global access to transparent information for patients. Because remember, our Medicare patients don't need a primary care referral to see a specialist for the most part. Medicare Advantage, many of them do. But for our Medicare patients writ large, if they were armed with better information and if that information included quality as well as price infrastructure, I think that could be a helpful place to start.
Right. Cheryl?
Great question, Jim. What I would add to those really beautiful answers is risk-adjusted in reporting data, I think, is really important. And then timely insight. As we start to understand value, what's important for ACOs who have risk, and while we're in this transitional model, is really timely insight, not, even, daily, right? Just understanding what's going on, I think, is really important as you work to build all the things that we just talked about. But as an ACO, and we're managing and trying to engage with specialists, timely insight would be a good thing to be able to understand. And then any kind of reporting, I think you have to consider risk adjustment, because it's so complicated when you're doing value equations.
Right. Walter, and we'll see if we can get your question in real quickly. We've got just a few minutes, a couple of minutes.
I'll try to make it quick. I wanted to add my thanks for the panelists for being here today. It's really great hearing all these perspectives. Also, hats off to the PCDT team for convening this panel and the wide variety of ACOs represented here, from one that focuses just on mainly on primary care, another both primary and specialists are welcome, and a third on Medicaid. This is a question, actually, it's a two-part question. Hopefully they're not long answers necessarily, though. For Emily Brower, wanted to revisit this concept you mentioned of attribution eligible specialists. I believe you said nephrology, cardiology, and oncology were the ones that you kind of focused on. So for the Trinity ACO, the first part of the question is: are these attribution eligible specialists attributed patients solely or jointly with their primary care provider?
Yep, and pulmonology is in there too.
Oh, pulmonology, sorry, I missed that.
So those are ones that CMS and the ACO attribution methodology includes, and where we see that sort of claims-based attribution falling the most in those four. The attribution is to the ACO, and I don't know, I'll try not to take us down a rabbit hole there. So, yeah, I would say it is the combination of the entity or the TIN they're billing under and all of the providers that are included in that TIN. So really the attribution is to the ACO. It's not from CMS. What we then do is say, when we see that attribution that includes both primary care and one of those subspecialists, right, we sort of internally assign or attribute those patients to primary care as their primary care provider. When there is no primary care, then those subspecialists or those IM subspecialists become the primary attributed provider. So a little bit of sort of just technical. We get the data. CMS doesn't really attribute it to an individual provider. We do. And we sort of take that data and parse it out and assign it. And for patients who do not have a primary care provider, one of the first things we do when we get the list of new patients is find out from that specialist, does that patient need a primary care provider? Like maybe they're happy and they're just not in our network. That's okay. But if they need that coordination, let's get them connected and start sort of effectively co-managing or coordinating that care together. Does that help?
Yeah, that helps. And I guess the follow-up question to that is, it sounds like then from what you just said that these attribution eligible specialists probably participate in shared savings in the same way that a primary care provider might, if they had kind of sole attribution for that patient. What if they had joint attribution with a primary care provider? How are they paid?
So they're just receiving fee-for-service, and then the benefits that I spoke to earlier of being in the network. I will say we went down the road of, do we attribute the shared savings to them? Do we give them a PMPM? Is there a share? And when we talked to the specialists, because sort of they are us, they said, no, that's not really meaningful. It's not going to change anything that I do. Let's just work on how we work together, remove barriers, address pain points. Let's just actually try and be a network of providers and really a medical home for that patient, and don't send me checks. So I know that there are people out there who probably hear differently, but I will tell you that was like a lot of where we started and then sort of backed off from, because that's not what we heard was meaningful to the specialists.
Thank you for that answer, and I want to thank the panelists tremendously for their time today. Clearly, lots of experience and expertise on this panel, and you've given us a lot to think about and take back to chew on. So You're welcome to stay and listen as much of the rest of the meeting today as you would like. I would love to have you continue to listen. We're going to take a short 10-minute break now, and then we'll come back for the next session. Thank you all.
Produced by the U.S. Department of Health and Human Services.